This is a phase 2 study specifically for patients with Waldenstrom's macroglobulinemia who have been previously treated. And what we're doing, we're combining two agents. One of them is a new non-covalent BTK inhibitor called pirtobrutinib, and the other one is a BCL2 antagonist called venetoclax. In our laboratory, the combination of a BTK inhibitor and a BCL2 antagonist have shown to have a much higher power to kill Waldenstrom's macroglobulinemia cells. We have done previous studies in other malignancies in which we have combined these agents, and these regimens have been highly effective. So inspired by that, we decided to run this study. And the idea of this study was to accrue about 42 patients with Waldenstrom's macroglobulinemia. We'll give them about a month of pirtobrutinib, and then we will add venetoclax during the second month in a ramp-up phase. And then we will continue this concurrent regimen for about 2 years. And at that time, we will stop therapy. The idea of this study is to provide patients with Waldenstrom's with a new treatment option that will be all oral, non-chemo, finite duration. So our study, what I'm presenting this time is about our experience on the first 27 patients who have been on treatment, on study treatment for at least 6 months. And for us to think about how we design a study, how successful a study is, we decided that if we can induce a very good partial response, which means a decrease of at least 30% on serum IgM in at least 35% of patients, compared to a 15% of patients, which will be the null hypothesis, we will call this study successful. For that, we will need at least 12 patients to have obtained a very good partial response. So between May 2023 and July 2025, we actually enrolled 36 patients, but I want to present data on the first 27. And when we looked at the first 27 patients who completed 6 months of therapy, we see that we have been able to attain at least a very good partial response rate of 56%. That means 15 patients have actually gotten to the outcome that we wanted. So we have exceeded the expectations of this study, and for that reason, this study has met its endpoint. Interestingly enough, we have been able to observe that 3 patients have gotten to what we call a complete response. And a complete response is hard to achieve in patients with Waldenstrom's macroglobulinemia with standard regimens. Typically, the complete response rates are in the single digits. So being able to obtain, a more than a 10% complete response in patients with Waldenstrom's is very encouraging for us. Now, obviously, this study will continue to complete the accrual and to, at some point, stop therapy in all patients. In that way, we will get a better sense of what the duration of the response and the progression-free survival is going to be in patients once we stop therapies. And an interesting aspect of things is the genomic makeup of the cancer cells. So we do have patients who have MYD88 mutations, and that includes all the patients in this trial. We do have patients with CXCR4 mutations that were about 40% of the patients in the study. And we also see patients with TP53 mutations that included about 20% of the patients in this study. So far, with the data that we have, which is a little early, we have been able to see that CXCR4 mutations might delay the time to the response a little bit, and also TP53 mutations. So it looks to me that these mutations might actually have a role in terms of how we treat these patients. Obviously, it's a little early, and we need much longer follow-up to understand, what the impact of these mutations is on these treatments. But on the global scale, I do believe that this combination has shown a depth of response that, if it is sustained, will provide patients with Waldenstrom's with an additional new treatment option that was not available before. The toxicity of these treatments were as expected, with the most common side effects being hematological, meaning decreased white blood cell counts and some anemias and thrombocytopenias. But these tend to be transient, and as the treatment continues and stops, these end up resolving. And so far, I think this is important. We have not seen any concerns of tumor lysis. We have not seen any concerns of arrhythmia, which is what we have seen with previous versions of BTK inhibitors, and therefore seems to be not only an effective regimen, but also a very safe regimen.